Could you show us how you would perform this procedure closer to the knee?
Sure. So kind of a good starting point would be to scan toward the popliteal fossa here and look for your artery and vein here. We clearly can see our sciatic nerve kind of with its tibial and peroneal components here. And I've traced the nerve now just proximal to the popliteal fossa, and here once again is a fairly nice view of the sciatic nerve in its entirety. As you trace more distal, then you start to see the split. On the left side of the screen laterally you have the peroneal component, and medially you have the tibial component, which you've highlighted with the arrow here. So certainly if you were going to do this more distal, you could approach the nerve at this point here, where it's together here. Once again, here's my needle that you can see on the screen, and I'm just deep to the nerve here, but I can approach the nerve and then once again stimulate fairly close, and I'd probably just back off slightly to maintain that at least 1 centimeter distance away from the nerve. And once again, I'm coming now lateral to medial, so I'm closer to the peroneal component of the nerve. Certainly I could come from the other direction if I needed to, or go underneath the nerve if we were targeting the tibial component. Once again, just tracing laterally, you can see the split that happens with the peroneal component here and the tibial component of the nerve here.
Do you have any anatomic concerns in terms of performing the procedure?
You know, certainly you always want to know and use good Doppler here at this area. Depending on the patient, there may not be a lot of tissue, and so making sure that you're far enough away from the vasculature is important. And certainly you don't want your lead to cross a joint. This could be obviously a mobile part of the body, and there could be an increased risk for inadvertent dislodgement of your lead. So those are some of the concerns that I have.
And where would you place your battery?
Yeah, so the pulse generator, once again, we put on lateral thigh above the knee would be a good placement site if you were targeting the nerve at this area, this level.
And what type of paresthesia or motor contraction are you looking for?
So paresthesia-wise, we would expect mainly paresthesias below the knee. So the common and superficial peroneal, this is going to be lateral leg down to the dorsum of the foot. And the tibial component, or if you know, you would expect more paresthesias along the plantar surface of the foot. Motor, we discussed, you know, tibial versus peroneal, which would be plantar flexion and dorsiflexion respectively. One thing that Dr. Odestad brought up earlier is oftentimes my default is to start closer to the nerve and then start to withdraw your needle to a point where you're getting good sensory stimulation and patient discomfort is minimized.